Hi, Farmies. We're going to do anti-infectives. That's just a fancy word that is an umbrella term. It covers antibiotics, antifungals, antiprozoals, and we're not even covering all the antis. So, yeah, I cut the list back a little bit, so you'll notice that it's a little shorter. There's a few less drugs than on our original list, and I will post that updated Excel spreadsheet that has all of your class dates, et cetera, on it. But it also has the list of drugs so you can see. But what's on this PowerPoint is all inclusive of the drugs that you need to know for this particular unit. Okay, true or false? Antibiotics kill bacteria. True, they do kill bacteria. True or false? Antibiotics kill fungi. And the answer is no. False, they don't kill fungi. Antifungals kill fungi. And then true or false? Antibiotics kill viruses. And the answer is false. Antivirals kill some viruses. So not antibiotics, antivirals. Those are different. Biotics is bacteria, right? Biotic. And viral is obviously for virus. So those are different. And those are different classes of medications. And you can't just lump them all in together. Okay, so let's talk about some key terms that you need to know. And you probably remember these from your microbiology class or perhaps, hopefully, microbiology. So gram-positive, it just means that it retains color after gram staining. And remember that determining whether something is gram-positive or gram-negative is just one way that you can tell bacteria apart. There are only certain bacteria that are gram-positive and only certain ones that are gram-negative. So that's one way that you can kind of, as you're growing something out on a plate, right, you do a culture, you see something growing, and you begin to look at it, there's all these steps that you go through to determine what kind of bacteria it is or what kind of organism it is. And I know you guys did this in micro, and this is very important. It's why we have microbiology labs in hospitals that also do the very same thing. So gram-positive and gram-negative. And in terms of those two organisms, gram-negatives are much nastier than gram-positives. Gram-negatives tend to be things that our bodies are pretty good at kind of filtering those out. Like your spleen is really good at catching gram-negative bacteria. There's something that we tend to see more when you have an immunocompromised patient. So just so you know. And then, sorry, I just noticed a typo. It should be E. coli, not K. coli. E. coli, Klebsiella, Pseudomonas. Wow, I did great on these. Salmonella. And again, remember, these are things that tend to occur more in people who are immunocompromised or sick, compromised in some way. Then there's bactericidal versus bacteriostatic. And these are really important. They're important from the standpoint that bactericidal, similar to the word suicidal or homicidal, it kills the bacteria. So cidal means that if we say that an antibiotic is bactericidal, we know that it's going to go in and actually kill the bacteria. Some antibiotics are bacteriostatic. Bacteriostatic means that the antibiotic goes in and it slows down the bacterial growth, right? And it makes it hard for that bacteria to grow, but the host in whom we're treating the infection their immune system also has to come in and have good, strong defenses to help finally kill that bacteria. So it's sort of like, if you were going to use like a hunting analogy, bactericidal goes out and, shoots the animal and done, gone. Bacteriostatic would be, going out and something that holds or pins the animal down, slows it down so that then it can be killed by the body. So those are important to know, and the bacteriostatic piece is very important to know because, again, you have to have a healthy host that can have its own good, strong defenses. So in someone who is maybe fighting a kind of a minor infection and they're going to be treated on an outpatient basis, getting something that's bacteriostatic, depending on the bug, might be just fine because they're healthy, they're in good shape, other than whatever this infected thing is. Let's say it's a hangnail. Whereas bactericidal is going to be a little more intense. And then aerobic and anaerobic, and you guys know the difference between those. These are bacteria that grow best with oxygen versus bacteria that grow best without oxygen. And these become important when we think about kind of infections that we see. So for instance, even though we have, oxygenated tissues, something that's growing inside of a brain or the bone tends to be more anaerobic, right? Those aren't good, highly oxygenated places versus like lungs or the GI tract. So just something to keep in mind. Antibiotic resistance. Mutations occur spontaneously and randomly in bacteria, and sometimes they result in sort of a reproductive advantage over their neighbors. And so if you watch this video, which you really need to watch it if you don't remember antibiotic resistance, it's super well done. It's done by Ted Ed, and it will describe how antibiotic resistance occurs. And then I want you, after watching it, to answer these questions, which you should be able to answer is, why are hospitals great places to find drug-resistant antibiotics? Sorry, that should be bacteria. And then how can we reduce the presence of drug-resistant bacteria? So you might think about that because nurses play a very important role in teaching patients about antibiotic use, in being a member of the healthcare team where perhaps antibiotics are being used. So we are also monitoring the patient's response to that antibiotic. But these are really important questions to answer. So which antibiotic do you use? And sorry for the gun pictures. I hope they don't trigger anyone. No pun intended and no trigger intended. But they are just such good analogies for these antibiotics. So broad spectrum antibiotics have the ability to kill lots of different kinds of bacteria. And so they're a great drug to use when you don't know exactly what's causing the illness, right? And we use a lot of broad spectrum antibiotics in outpatient care. You go in, you don't feel well, doctor decides you have a bacterial infection of some sort. You'll typically get a broad spectrum antibiotic because we're not going to culture swab everyone's nose and all of their different body orifices to find out what the offending organism is. We're going to make some assumptions based on kind of what typically and commonly occurs in the community. So that's what broad spectrum is. Narrow spectrum are antibiotics that really are more like the handgun. So the broad spectrum is sort of the machine gun. It sort of kills everything. And the narrow spectrum is more targeted and actually works on a particular bug or a particular type of infection. So those are important to know. And a lot of times what we'll do when we're doing treatment is we will see someone who's sick. We will take a culture. We will, while we're waiting for the culture results to come back, we'll start the patient on a broad spectrum antibiotic. And then when we get the culture results back and we know exactly what bacteria we're dealing with, then the patients will often be switched to a more narrow spectrum antibiotic, which I think makes a lot of sense. Okay, other things that we have to think about. So culture and sensitivity. I know you guys did this in microbiology. So this is a culture plate, and on it are little antibiotic soaked pieces of discs of paper, right? So they put them on, and what they're looking for is they're looking to see which antibiotic shows the greatest cell kill. And if you look at it, like this one looks really good. This one seems to work really well. This one seems to work pretty well over here. This one doesn't seem to be working at all. So the bacteria are either resistant to it or not sensitive to it. So this is how we decide what we're going to use in terms of what's the best drug for the patient. And then hopefully we have a few choices so that we can, take into account the patient's condition as well and give the drug that provides the greatest benefit with the least amount of side effects. So we'll do a culture, and this question here, when should cultures ideally be taken? Well, they should be taken before antibiotics are started. If antibiotics kill bacteria and we want to know what kind of bug the patient has, what kind of bacteria is infecting the patient, why would we give antibiotics and then do the culture? That makes no sense. We would do the culture first, then we would give the antibiotics. Cultures like this kind of a plate and a culture and sensitivity usually takes between 3 to 5 days. So during that time, you as the nurse can be checking the lab results to see, are the cultures back yet? And helping to, move along that process of when the physician switches over to a narrow spectrum antibiotic. Or maybe the broad spectrum that they put the patient on initially is perfect and that's what they're going to stay with. Usually we do single drugs, meaning one antibiotic. We don't usually hit people with a whole bunch of different antibiotics. But sometimes patients are really sick. And if they have maybe different infections in different areas of their body, or they have really serious infections, they may use multi-drug therapy. So I've seen as many as 3 or 4 antibiotics used in patients who are immunocompromised and neutropenic. So some of the side effects that you're going to see from different antibiotics are things like super infections. So remember, our bodies have all kinds of bacteria in them normally. And, we talk about the gut microbiome. That gut microbiome is really important. And when we start hammering it with antibiotics, we can sometimes, in addition to killing the bad guys, we can also kill some of the good guys in there that help keep things stable and functioning well. So that can then, if you lessen some of the good guys, then all of a sudden you give bad bugs an opportunity to maybe have overgrowth. So we call those super infections. Pseudomembranous colitis is a potentially fatal complication. I'm sure you guys have, if you haven't seen C. diff or a patient with C. diff, you will, I guarantee it. C. difficile is a bacteria that loves to multiply in the gut, especially after antibiotic use. And it's usually been after sort of a long run of antibiotics. So maybe somebody who has a serious infection like a brain infection or a bone infection that's going to require much longer therapy might, after several weeks, end up developing C. diff, which can be really miserable, really hard to treat. It's a whole nother discussion in and of itself. So risk factors for these super infections are things like broad spectrums, right? Because again, the machine gun, it's going to take out the good and the bad bugs, or high dose antibiotics, again, very toxic to many different kinds of bacteria. Proton pump inhibitors, which we haven't talked about yet, but we will soon. They can lower gastric acidity, and gastric acidity helps regulate your gut microbiome. So if the patient's on proton pump inhibitors and they're on an antibiotic, that can cause problems. And then tube feeds. If your patient's getting a tube feed, either through an NG tube or a G tube, patients can end up having really significant infections because these tube feeds are just full of sugar and starch and are just wonderful breeding grounds for bacteria. So that can also cause major problems. Same with TPN. TPN is also just a bug heaven. And so you have to be really careful. Things like, making sure that you're doing all the proper care of those tubes, the right flushing, changing tubes when they need to be changed so that we minimize the risk of infection. Long-term use of antibiotics is something that can be, limiting long-term use of antibiotics can be really helpful. Judicious use of proton pump inhibitors and adding fiber to tube feeds. Those things can all help with sort of decreasing the risk for C. diff. And then Candida albicans, we talked about this. And this is the yeast, fungus, but it's really yeast, that causes thrush. So remember, we talked about this in relationship to using inhaled steroids, that those inhaled steroids inevitably get on the walls of the mucosa in the mouth. And if you don't rinse that off, it can cause immunosuppression right there at the walls of the mucosa, and you can get thrush. So, but again, even on antibiotics, we can see people get thrush as well. Because again, we're messing with the good bacteria that protect us from the bad bacteria. So again, here's your culture plate. And it's always really interesting to read the reports that come back and see, like, what are they sensitive to? And then, we have infectious disease doctors, and all they do is treat infectious disease and give us, amazing insight and advice on how to handle patients who have really complex cases. So remember, we have all these specialists that we can, tap into. And as a nurse, it's really important that you guys get comfortable going in and looking at those reports. We know that, if you know that pulmonary is going to come see the patient, and maybe, you've had the patient for a few days, go look for the report and see what they said and what their recommendation is. That's part of you knowing the whole story of the patient, not just blindly following the orders that are written in the chart. Okay, so when we're looking at host factors, there's several things that we need to look at. And one of the things you have to look at is, what's the goal of giving someone antibiotics? Because we can give antibiotics even prophylactically. Just think about that. Anyone who has a heart stent or heart valve issue will probably take prophylactic antibiotics before going in and getting their teeth cleaned. And that's because the dentist is going to disrupt a bunch of bacteria off of your teeth. And of course, they always make you bleed when they do that. So there's risk of seeding the bloodstream with a bacteria. And then anybody who has a heart valve problem or a stent, Remember, those are places where the blood flow is disrupted, and so infection can set up housekeeping. So sometimes we'll give people antibiotics just for a few days before they go into the dentist. Or maybe the goal is to go in and, wipe out all the gut bacteria because the patient's going to have gut surgery. So it just depends. You also want to look at the place of infection. And we talked about this a little bit earlier, aerobic and anaerobic. So is it the brain versus the lung versus the bone? How well an organ is perfused with blood will also determine how long we have to give an antibiotic. For instance, a bone infection, like an osteomyelitis, that patient will probably have to be on IV antibiotics for at least a week or two, could be even longer, and then possibly on oral antibiotics then for many weeks after that. So we have to look at that and see. We want to look at the immune system status of our patient. Are they immunocompromised, meaning they don't have a good, strong immune system? Maybe they're getting chemotherapy. Maybe they're on an immunosuppressant regimen. Maybe they're taking prednisone chronically. So we have to look at that and see how they're doing. We have to look at the other medications that they're on. Some antibiotics don't play well with other drugs, and so you need to look closely at that. You need to look at the age of the patient. Is the drug harmful to someone who's very young or very old? One of the drugs you're going to look at is tetracycline, and tetracycline should not be given to children under the age of 8 because it causes tooth enamel problems, and you don't want kids to mess up their teeth. You want to look at allergies. Some patients have documented allergies to antibiotics. Antibiotics are well known for causing allergies in some patients. You want to look at pregnancy status, and then you want to look at race. Some different populations may lack certain enzymes to metabolize particular antibiotics. So again, in order to give good care, we need to make sure that we're giving an antibiotic that's going to be effective. So here we go. We're going to go into our prototypes. Penicillin, and you guys are probably all familiar with penicillin. It was the first antibiotic discovered. It is bactericidal and used for gram-positive organisms. Now, let me say something about this information, bactericidal and gram-positive. I do not expect you guys to remember that. I don't think it's important to the drug itself. So when you see me put that on these slides, it's more there as a point of information. It's something that you can look up in a drug book. But again, I want you to understand what bactericidal means. Okay, and then penicillins have this ring called the beta-lactam ring. And if you look in your drug book, you will see this well described in your pharmacology book, your pathopharm book. The beta-lactam ring is part of the chemical structure of penicillin, and it is thought to be what is responsible not only for the antibacterial activity of the drug, but also what can cause people to have allergies or anaphylaxis to this drug. So it has the beta-lactam ring, and when you get resistant microbes that are resistant to penicillin, it means that they have somehow been able to do a workaround for that beta-lactam ring. You have on an empty stomach, observed for electrolyte balance. Most penicillins are attached to sodium or potassium salts. So you just want to watch. If your patient doesn't have any electrolyte issues, it's probably not going to be a problem. But if they do, or if they're having like significant water retention, and you're really trying to control like sodium in diet and other things, this is something to consider. It's just another source. And penicillin is rarely given by itself anymore because there's become so much resistance out there. So they'll often mix it with something else. And the famous one that is used a lot, it's used a lot for sinus infections, is Augmentin. And so Augmentin is penicillin and clavulanic acid together. And penicillin and clavulanic acid have this synergistic effect, meaning they both work better together than separately. It's used for ear, nose, throat, lower respiratory tract infections. Now, here is a biggie. It can decrease effectiveness of birth control pills. Yowza. So if you have a young patient or a patient who is on birth control pills, you want to know that, and you want the physician or the provider to know that, because you want them to be aware that this could decrease the effectiveness. And it might be that you need to counsel your patient to use another form of birth control while they're on this antibiotic, because it'd be a bummer to go on penicillin and have a baby or get pregnant if that's not what you were planning. Cephalosporins, this is the next. Oh, so let me go back. Penicillins, these are considered classes of antibiotics. So I don't know how to say this except that there are different families of antibiotics. So this would be like the penicillin family. Now we're going to move on to the cephalosporin family. So under cephalosporins, there may be 20 different drugs. If you look again in your pharmacology text, you'll see all of the many different types of cephalosporins. You're not going to learn them all. You're just going to learn one. But it just so you know, in terms of this particular type of antibiotic. So note the ceph. And you'll see that ceph sound or spelling in many of these drugs. So I'm actually going to get to that in the book so that I can give you some examples of that. So here we go. And just so you know, cephalosporins, there are first generation, second generation, third generation, fourth and fifth generations. And I believe we're actually up to a sixth generation. So these are just different iterations, different versions of cephalosporins that have gotten more and more refined over time. They tend to have less side effects, or they're more specific to a particular type of infection. But listen to the names of these cephalosporins. So you guys are learning cefazolin, but there's cephalexin, cefaclor, cephatan, cefoxitin, cefuroxime, cefdinir, cefixime. Yeah, there's tons of them. So I just want to, that ceph, when you hear ceph, that immediately means it's a cephalosporin. Now, these are also bactericidal, and they inhibit cell wall synthesis. Again, I don't expect you to know that, but I do want you to know that cephalosporins also have a beta-lactam ring. Well, so now you have penicillins that have a beta-lactam ring, and you have cephalosporins that have a beta-lactam ring, and the issue is that, again, this is responsible for antibacterial activity. But if you have someone who is allergic to penicillin, you probably don't want to give them a cephalosporin, and vice versa, right? Because we think the beta-lactam ring is responsible for some of the issues that people have with these drugs, the allergic issues. So it doesn't mean that you won't give cephalosporins to a patient with penicillin allergy. It doesn't mean, or vice versa, but it does mean that you should question it. So you just want to make sure. I had a really interesting case when I was working on a post-surgical unit where a patient had very significant penicillin allergy. The nurse noticed that the patient had been given a cephalosporin drug perioperatively. So one dose before surgery, one dose in surgery, and was getting a couple doses post-surgery. And questioned the physician, and the physician said, well, this patient's already gotten a couple of doses and seems to have done fine. And so the nurse went and hung the post-op dose of cephalosporin, and the patient had a massive reaction. And so that became one of her very well-documented allergies, that she could not get penicillins or cephalosporins of any kind. But it's not usually that serious. But I just want you to be aware of it. That's a very important thing to be aware of. Mostly given IV, food delays absorption. Now, here's what I'm going to tell you about food and antibiotics. Most people can't take antibiotics without some food in their stomach. If you are going to do that, avoid dairy. And the reason is that dairy tends to, the calcium in dairy can sometimes bind to these drugs. So if you're going to give them cephalosporins, give them some crackers and some juice, or any antibiotic, even if it says to take, ideally on an empty stomach or whatever, because most people cannot tolerate antibiotics on an empty tummy. You want to be careful with patients who have renal or GI disease, who are taking diuretics. Those folks can have complications. And cephalosporins, and you can remember the C, cephalosporin and C. difficile are sort of tied together. So not that other antibiotics can't lead to the development of a C. diff infection, because we have C. diff in our gut all the time, but our normal flora in there keep it under control. However, cephalosporins, especially long-term cephalosporins, tend to really wipe out the gut bacteria. So I do want you to remember that cephalosporins are directly related to C. difficile. And then don't use in children younger than 8. Affects tooth color and form. Oh, you know what? I think that, well, you can keep that on there, but I'm pretty sure that that is more related to tetracyclines, but I will double check it for you guys. Okay, tetracyclines. Now, tetracycline, a lot of people take this for acne, right? So we don't see it a lot in inpatient clinical practice, but you will see it more in outpatient. It is a very, very safe antibiotic, has been around for a long time. It's bacteriostatic. So again, the patient has to have good defenses. And if you think about it, we're often giving it to teenagers. It could be given topically as an ointment, or it could be taken actually as a pill. So that's great. Actually, where it says bacteriostatic in larger doses, it should say bactericidal in larger doses. It's given on an empty stomach, but often causes GI upset. So again, there's my word of wisdom about taking it with a little something. It's really good for treating H. pylori, which causes stomach ulcers. And that's just been in the last 10 years that we've been using tetracycline for that. So, and then again, can cause renal hepatic dysfunction. This is the way that these drugs are metabolized and excreted. And we already talked about H. pylori. Okay. Fluoroquinolones. Now, this is ciprofloxacin. And remember, cipro is different than ceph, so don't get it mixed up with cephalosporins. Ciprofloxacin is a fluoroquinolone. It's a second-generation fluoroquinolone. Again, fluoroquinolones is just another family of antibiotics. Cipro is very commonly given, the most widely prescribed drug in this particular class of fluoroquinolones. Can cause some GI problems. Here's the thing I want you to remember about fluoroquinolones. It can cause tendinitis and tendon rupture. And so you want to be very careful about giving this drug, and you want to teach your patient that while they're on this, they need to report any signs of muscle tenderness, or if they feel any kind of tearing or pulling, they need to be seen. So we want to be really, really careful with this, because a ruptured tendon, like a ruptured Achilles, whew, that is a game ender for a little while. You're definitely going to be off your feet, not able to do stuff. Again, do not take PO formulations with antacids, because it'll decrease drug absorption. Antacids don't play well with most drugs, so just so you know, especially the ones that are like Tums, the chewable kind. Many, many drug interactions with fluoroquinolones, so you're going to have to be really careful when you are giving this, just to make sure that your patients aren't on. There's some things with blood thinners and some other medications, but you don't need to know that. I just want you to know that there are many drug interactions with that. Okay, and then we have this tricyclic glycopeptide. Don't worry, you don't need to know that. I'm never going to ask you that on a test. I'm only going to talk about vancomycin. Vancomycin, the reason that you're learning this drug is that it is the standard treatment for MRSA, methicillin-resistant Staph aureus. MRSA, actually now it's considered now they call it multi-drug resistant Staph aureus. That's what it is, multi-drug resistant Staph aureus. And it started out as methicillin, and now it's many different antibiotics. So vancomycin is important because you will be giving it. It's bactericidal. It has a very high toxicity level and has a very narrow therapeutic index. And so we're going to need to do drug levels with this particular antibiotic. And I will teach you about that in class. So peak and trough is something that we're going to learn about, and it needs to be done at least once a week, or if there's a dosage change. So let's say we do peak and trough. Usually it's done around second or third dose, however many doses it takes for the patient to get up to sort of a stable drug level. Let's say it's peak and trough at third dose, and it comes back and the drug isn't high enough. There's not, the peak and the trough are so that it's too low to be effective. Then they'll adjust the dose up a little bit, and then the nurse will again do peak and trough around the third dose. And we'll keep playing that game until we get it right. Vancomycin, similar to your friend Lasix, can cause ototoxicity and nephrotoxicity, very significant. And so you need to be careful. This drug also has some super fun side effects. So this is an irritant, and you should be using a central line. At the very minimum, you should be using a PIC, a peripherally inserted central line. You should not really be putting vancomycin through a standard peripheral IV, because the vessels in the arms and hands, legs, wherever you're putting the IV, are not big enough. There's not enough blood flow in there, and what happens is that the drug really irritates the vessel. So it needs to be given through a central line. Central meaning that it goes into the central circulation, which means near or in the heart. And then this drug, it's a fun one. It can cause anaphylaxis. Literally seen patients turn gray. We had a patient who, every time we gave her this drug, she basically coded. but she needed it for a very serious infection that she had. It can cause red man syndrome, which is a combination of hypotension, flushing, and a rash on the upper body or face. Now, red man syndrome often occurs because the drug has been given too fast. So this drug is given over 90 minutes. Most antibiotics are somewhere between 15 minutes, 30 minutes, some are an hour. This is really the only one that's up there and is at least 90 minutes. And I'll just tell you, when I give it, I will give it over 2 hours. And then you need to monitor their blood pressure during the infusion. And if you start to see that their blood pressure is dropping, but they don't have flushing or a rash, you might want to back off on the rate a little bit and slow it down a little bit. These are some of the discretion that the nurse has in terms of giving this medication. Okay, moving on to antifungals. Our only antifungal is going to be nystatin. And this works so well because we've already talked about thrush, and this is the drug for thrush. So it's a superficial antifungal. It binds to sterols. Now, sterols are fat molecules in the fungal cell membrane. And so it binds to that and it weakens the membrane, which then destroys the fungus. Nystatin comes in almost every kind of formulation you can think of, except IV. It cannot be given parenterally. It is extremely toxic that way. And even if you give it orally, like a nystatin swish and swallow, when it goes through the GI tract, it's not absorbed. So it's still considered a topical drug, even if it's swallowed, because if you think about it, from your mouth to your anus, it's just like having a giant tube inside your body, right? It's like having, it's like a passageway that goes all the way through. So that would be considered sort of an outside tissue. I know it sounds kind of weird, but really you have epithelium all lining your GI tract and then out to your anus. So then it's mostly used for Candida, C. albicans, which we also call thrush. And for thrush treatment, you'll do swish for 2 minutes. Some people will do swish and swallow if it's felt that the thrush has actually gone down the patient's esophagus, because just swishing won't get it to their esophagus. So then they actually have to swallow it to get it down there and coat it. Patients do not like it. It doesn't taste good. Not something you really want to take when you're not feeling well. Another thing you can use this for is you can use nystatin powder on babies that have serious fungal diaper rashes. So it's not very common, but it does happen, and it works well for that as well. Okay, and then our last drug is an anti-protozoal, and that drug is metronidazole or Flagyl. It kills amoebas. It's the preferred drug for Giardia or trichomoniasis. It's a very interesting drug. Metronidazole, not only is it an anti-amoeba protozoal, amoeba is a protozoal organism. It has antibacterial properties against anaerobic bacteria, so it can be used for respiratory, bone, skin, CNS infections. It has anti-inflammatory properties, so it can be used for rosacea, which is like this reddening that you'll see on people's cheeks and nose, especially in older folks, and Crohn's disease. So here's the deal, though. Metronidazole is carcinogenic, meaning it causes cancer in lab animals. And even though we don't have any data to support that it does that in humans, it shouldn't be just used willy-nilly. It shouldn't be used just as a flinger to try. It's something that should be used only for its approved indications, meaning the conditions for which it's been studied. in a clinical trial. Common side effects are anorexia, nausea, diarrhea, so a lot of GI, and it can cause bone marrow suppression, meaning that it can cause your stem cells in your bone marrow, those same stem cells we learned that make white cells, red cells, platelets. It can tend to cause those to not be as productive. And so for people who have like anemias or other blood problems, you do not want to give them this drug if you can avoid it. Okie dokie. Nursing considerations. This is going to be your assignment, folks. And your assignment is that you need to make a poster or a flyer or a brochure, some kind of teaching tool. It's your choice. You don't have to make all of those. Just pick something to teach your patient how to care for themselves when they're taking an anti-infective. So choose one of the prototypes that I just went through, and you'll be creating a patient education item with that. Feel free to be creative. You can color, you can work. If you don't want to be creative, I get that too. Huge hint. You need to look at the nursing practice application pharmacotherapy with antibacterial drugs table. It's on page 524. It goes to page 526. It's like a giant care plan for someone who's on antibiotics, and it is going to give you a multitude of things that you can teach your patient about. I want you to have at least 10 distinct teaching points. So, are there any that are specific to the drug that you're choosing? Let's say you choose vancomycin, right? You may need to teach them about red man syndrome and some of those things. So you want to do that, and then you want to give me a rationale for why you're teaching each point. Again, if you look at the nurse practice application, a lot of what you need is right there. This is due on Sunday, December 4th at 5 p.m. Do not email them to me. Please upload either a document or take a photograph of what you've done. If it has multiple sides or pages, make sure you take pictures of each of those and upload those to Blackboard, to the teaching assignment that's in there. And then when I come back, we will talk about this more in class a week from today, which is December 5th. And we will talk more about some of these issues of treating people with antibiotics. It's a huge part of a nurse's job. And so the teaching that you come up with, that you learn about, is going to be really helpful to you, to your own learning as well. All right, guys, I hope that helps. Take care.